Hello, I'm Neil Dilworth, and today we're going to be talking about how to manage sports medicine emergency cases in the sports medicine exam. We're going to start off with a few cases, then go over the objectives, and then talk about how to approach these emergency cases. Case number 1. You were asked to see an equestrian for difficulty with breathing. He had recently started taking a new anti-inflammatory in the last 24 hours, started by his physician. He sits on his horse, sounding stridorous. The idea here is we want you to be thinking about what you want to be doing next, who you want to call, what kind of equipment you need. Are there any safety concerns as you approach the athlete? And try and think about that with each case. Case number 2. A 27-year-old runner in an August hot marathon finishes the marathon in 4 hours and 45 minutes. As she approaches the finish line, she stumbles, then collapses. You are the team physician for the event. Case number 3. A 19-year-old female during a varsity hockey game goes headfirst into the post, dislodging her mask. She is unresponsive on the ice with gargling breath sounds. So our objectives are to be able to describe the common emergencies that come up in a sports medicine exam, to understand the basics of managing emergencies for an exam purpose, and how to protect the cervical spine rolled patient and remove equipment. Below is not a fully comprehensive list, but for the most part, this will cover the majority of emergencies you're going to see on the exam. Airway, anaphylaxis, obstruction, and trauma. It's kind of an occasional event on the sports medicine exam. Cardiac, so a witnessed arrest. This is uncommon on the sports medicine examination, but is fair game for testing. C-spine injuries. This is almost always on the sports medicine exam. And metabolic, heat stroke, or hyponatremia. These are quite common on the sports medicine exam. Other emergencies that are not classified as emergency stations that you will see in an examination, so surgical, splenic rupture, intracranial hemorrhage, subdural hemorrhage, and then orthopedic specifically, fractures, dislocations, subluxations, ligamentous injuries, musculotendinous, and associated neuro and compartment syndromes. Other emergency scenarios that may come up but not necessarily classified as the emergency station, so laceration, severe weather, environmental risks, food poisoning, and infectious disease outbreaks, Zika, measles, flu, infectious mono, etc. So for your basic approach, we're going to talk about an emergency action plan. We're going to talk about leadership, how it's important that you take the physician role and the lead role in these emergency stations for the exam. And thirdly, simplifying the ATLS and ACLS protocol for exam purposes. Mainly the airway, breathing, circulation, in combination with C-spine immobilization, disability, and exposure. So we're going to take a look at C-spine video and log roll.
The first medical personnel on the scene is the leader. This person should issue all commands.
Can you hear me? You okay? No? There's no response. I want you to go get me some help. Call 911.
The leader should take control of the injured person's head. The leader holds the head with both hands, stabilizing it by holding firmly and allowing no motion.
We're going to have to roll him supine. I'm going to need one person at the shoulders, one at the hips, and one at the feet.
Direct all rescuers to reach across the injured person and grab a hold of the upper arm and shoulder, the pelvis, and the legs. Make sure to grab the body part and not pull on the article of clothing. Roll the injured person towards you upon the leader's call. Roll on 3.
1, 2, 3.
Roll the person down on the leader's call. Down on 3.
1, 2, 3.
If a spine board is available, log roll the athlete onto the spine board. The first medical personnel on the scene is the leader. This person should issue all commands.
We're going to need one person at the shoulder, one at the
The
hip.
leader should take control of the injured person's head. The leader holds the head with both hands, stabilizing it by holding firmly and allowing no motion. Position the other rescuers on one side of the injured person, one at the chest, one at the pelvis, and one at the legs. Place the spine board along the other side of the injured person, as close to him or her as possible. Direct all rescuers to reach across the injured person and grab a hold of the upper arm and shoulder, the pelvis, and the leg. Roll the injured person upon the leader's call. Roll on 3.
Ready? 1, 2, 3.
Direct the one remaining rescuer to place the spine board to where the injured person is just lying. Roll the person down on the leader's call.
Down on 3. 1, 2, 3. Okay, slide down on 3. Justin, come over here. Kelly, come over here. Koya, slide down. Slide down on 3. 1, 2, 3. Slide up on 3. 1, 2, 3.
Removing the face mask allows rescue personnel to examine the airway and vital areas of the face. It also allows them to administer pre-hospital care without removing the helmet. The face mask should be removed in a timely manner without moving the head or neck. Pruners, FM extractors, PVC pipe cutters, trainers, angels, and screwdrivers can be used to remove the face mask, although screwdrivers can be unreliable due to rusty T-bolts and screws. If needed, a bag mask valve can be inserted under the face mask to provide ventilation while the face mask is being removed. If a physician or EMS personnel is available, a more definitive airway can be secured if such intervention is necessary. If the situation is not as urgent, a cervical collar can be placed on the athlete, who then is placed on a rigid spine board to ensure immobilization of all segmental levels. This should only occur with athletes who are not wearing helmets and shoulder pads. Once the face mask has been removed, the athlete must be prepared for transport. Any injured athlete who may have a cervical spine injury should be immobilized on a full body splint. Techniques for spinal immobilization and the determination of whether inline stabilization is required for transport should be left to local protocols or the clinical judgment and training of the individuals who are on site. Positioning the head into a spine neutral position should be assessed on an individual basis. The equipment used in splinting athletes with head and neck injuries will depend on the appliances available, as well as the training and knowledge of EMS personnel. Typical equipment used includes the vacuum mattress and the rigid spine board. The following are different techniques used for spine boarding an athlete with a cervical spine injury. The lift technique. A 6+ person lift is recommended for all lifts. There should be enough ATCs, MDs, and EMS personnel to effectively administer the 6+ person lift. You may need a 10+ person lift for heavier individuals. You can also use a 4+ person lift for smaller athletes. Lifting with fewer than 4 people is not recommended. This step is omitted if you place the athlete on the spine board in the beginning. The first medical personnel on the scene is the leader. This person should issue all commands. The leader should take control of the injured person's head. The leader holds the head with both hands, stabilizing it by holding firmly and allowing no motion. Position the other rescuers on one side of the injured person, one at the chest, one at the pelvis, and one at the legs. Place the spine board along the other side of the injured person, as close to him or her as possible. Direct all rescuers to reach across the injured person and grab a hold of the upper arm and shoulder, pelvis, and leg.
1, 2, 3. And down on 1, 2, 3.
Once the athlete is on the spine board.
One of the questions that was brought up with respect to C-spine immobilization is if the head position or neck position is in a rotated position, do you neutralize that? And the answer is it depends. But if there is no resistance in terms of moving the head back to a neutral position, then move it back to the neutral position. If by chance neurological deficits occur upon moving to the neutral position, then return to the initial rotated position to see if those deficits go away. The second occasion where you don't want to put the head in neutral is if there's a physical block. So as you're rotating the head towards a neutral position, if you find that there's a block or a resistance, don't try and push past. The other question from the C-spine perspective came up in regards to the spine board. That is becoming more controversial, and in fact, recommendations are moving towards not using the spine board for transfer. That does not exclude, that does not mean to exclude C-spine immobilization. C-spine immobilization is still necessary. So an emergency action plan, we use the mnemonic PEOPLE for a reminder in terms of what's involved. But generally speaking, an emergency action plan is an organized format that can be, or protocol that can be used in an emergency scenario during an event coverage. It involves both people and personnel that can be involved, but from a communication standpoint, but also from a first responder and transfer perspective. It involves the equipment required for emergency protocols. That includes communication equipment, emergency medications, as well as personal protective equipment and other equipment such as C-spine collars, airway equipment, oxygen, and many others which can be seen on an attached list. Organization, so it's important to have an organized plan in place with respect to who's going to be the first responder, how they're going to communicate, to the event coordinators, as well as with paramedics, and how to coordinate paramedic arrival to the scene as well as their exit. Emergency action plan also has to take into account the patients and people at risk in an event. That could include bystanders, coaches, trainers, as well as obviously the athletes themselves. An emergency action plan also has to take into account the location of the venue, as well as the potential environmental risks associated, whether that's heat or electrical storms. It could involve working in a pool, risk of drowning, and it could also involve working in equestrian events or trampoline events where there are unique challenges present. In all, that encompasses the emergency action plan. In the emergency stations of the sports medicine exam, it's very, very important and vital that you take a leadership role. And that is to direct and communicate clearly the steps of care that you want to provide for the patient. Remember that you have a long time in these emergency scenarios. So it's okay to step back, assess, and then communicate clearly and directly so that your team that's available to you in the room, as well as the examiners, are fully understanding of what you're trying to do. If the team is limited, it may require that you perform some of the procedures and life-saving actions yourself, but the examiners will let you know if there's any other team members available. Your ATLS protocol. So it's very important that you ensure that the environment or field of play is safe to approach, whether that's an equestrian event and you have a live animal, trampoline, you have a unstable surface, swimming pool, where you have a potential for drowning, or whether there are loose electrical wires or other potential occupational risk factors such as gas leaks and the like. With respect to the ABCs, it's very important that you protect the airway, and there will be a separate lecture on how to troubleshoot through difficult airways, but that can involve positioning, jaw thrust, tongue retraction, nasal or oral pharyngeal airways, and laryngeal mask airways, intubation, and cricothyroidectomy. Supporting breathing with bag ventilation, breaths, and oxygen. And from a circulation perspective, beginning CPR after a witnessed arrest, asking and acquiring and then applying the defibrillator, accessing intravenous, and passive leg lift, which is essentially raising both legs to get an approximate 300 milliliter bolus. With cervical spine immobilization, that has to be kept in mind for all traumas from a sports medicine exam perspective. Disability, it's also important that once you've identified that the patient has a C-spine injury, to assess for any kind of associated neurological injury going from head to toe. And exposure. This is very, very important, especially from a sports medicine perspective when you're dealing with athletes wearing equipment, that you may need to take off the helmet and face mask, obviously, to access airway, and as well as to immobilize and splint orthopedic injuries and deformities, to consider reductions and cooling for heat stroke. One last reminder from an exposure perspective and an airway perspective is the use of mouth guards or gum shields, that those should always be looked for and considered to be removed in emergency stations. Your ACLS protocol, this is for your exam stations where you have a witness collapse, and that involves airway, breathing, and circulation, and compressions 30 to 2 in an adult. Also, that will involve getting an AED, So here's the application of the basic approach. So you've identified that you're in an emergency station. First thing you want to do is assess the environment. And you can clearly communicate that you're assessing the environment, looking for any kind of dangers upon approach, making sure that it's safe to approach, the field of play is safe, and that the play has stopped. and that you are now safe to access the field and the injured party. Then you're assessing for level of consciousness and whether or not there's loss of consciousness. Communication, that involves with the team, EMS, and the venue staff, as well as not just your own medical team, but potentially other people on the field or in the field of play. And then you want to prioritize your airway, breathing, and circulation, as well as the disability and exposure, and then provide supportive care. The idea is not to be able to diagnose the specific condition that has occurred, but to provide supportive care until there is appropriate transfer to a tertiary care center. That can include treatment of the airway, breathing, and circulation, application of equipment and procedures, such as supportive, like we talked about before, so temperature control. If they're cold, getting them a blanket. If they're hot, getting them cooling blankets, and application of fluids, oxygen, etc., as needed. So for case number 1, where you're asked to see an equestrian for difficulty breathing, and they've recently started that new anti-inflammatory in the last 24 hours, this is clearly an airway issue. And in this situation, your concern, given that the person recently had an anti-inflammatory and is sounding stridorous, is that they are having an anaphylactic airway. So the first thing you want to do is, as approaching the patient, make sure that you have and bring your medical bag with you. And once you approach, you want to be giving epinephrine, so 0.3 milligrams IM. So using an EpiPen, 0.3 to 0.5 IM, and then providing supportive care, oxygen, and then continuing to monitor the patient throughout. This is somebody that will require transfer to hospital for further monitoring, and may in fact require a second EpiPen during your case. It's important to continue to monitor the patient throughout, as in fact part of the station, as it could be up to 15 minutes long, may involve the patient deconditioning with time. Case number 2, where you have a 27-year-old runner in a hot, humid August marathon, and they finish the marathon in 4 hours and 45 minutes, and then stumble and collapse upon finishing. Here, once again, you want to assess the patient. You approach the patient, make sure that it's, once again, safe. There's no other risks involved with the environment. And you want to assess airway, breathing, and circulation. Once you've identified that the patient's airway is patent, that they're breathing and the circulation is okay, there's no neurological issue. Upon secondary survey, you find that their temperature is 39 degrees. This is a situation where a patient is suffering from heat stroke, and you want to treat appropriately. So this is all about supportive care, getting the patient fluids, cooling blankets, reducing the temperature, and preparing to transfer to a tertiary care center where they can get further treatment. Case number 3, you have a 19-year-old female who goes headfirst into the post, dislodging her mask, and lies unresponsive on the ice with gargling breath sounds. Concern here is obviously an airway. You want to make sure that the play has stopped and you have it's safe to approach. You're on the ice, slippery surface. You want to comment on that. You want to approach with your team and an equipment bag. You want to activate the emergency action plan early. And as you approach the patient, obviously you want to be able to access the airway. So you have the team both stabilize with C-spine immobilization in mind, and remove the face mask and helmet as quickly as possible with C-spine immobilization to access the airway. For further troubleshooting the airway, we'll ask you to review and observe the airway troubleshooting video. However, in this situation, the first thing you want to do is make sure that a jaw thrust is performed and a finger sweep is performed as well to remove the mouth guard, which will remove the obstruction. And then you want to provide artificial breaths and ventilation to support the patient and get oxygen, and once again continue to support the patient until EMS arrives. You can consider an oral pharyngeal or nasal pharyngeal airway until the patient regains consciousness, and continue to support the patient with C-spine immobilization until access of further care is provided. So in summary, using a stepped approach to assess, communicate, prioritize, and treat the patient is going to be very helpful. Call for help early and activate the emergency plan early. Make sure to step back and assess so you can lead if necessary, and using a basic approach the same way each time to stabilize and prevent further injury prior to transfer.